welcome to the recent approvals episode of the ASCO University Weekly Podcast. My name is Matt Yurgelun. I am an assistant professor of medicine at Harvard Medical School and a gastrointestinal medical oncologist at the Dana-Farber Cancer Institute's Gastrointestinal Cancer Center and Cancer Genetics and Prevention Program. Today, we will discuss the accelerated approval of Nivolumab for the treatment of patients 12 years and older with metastatic MSI-high mismatch repair deficient colorectal cancer that has progressed following cytotoxic chemotherapy with a fluoropyrimidine, irinotecan, and oxaliplatin. As a background to today's discussion, immune checkpoint inhibitors are active therapies in patients with a variety of advanced cancers, and in particular have demonstrated significant activity in individuals with cancers that demonstrate high-level microsatellite instability, also known as MSI-high, and mismatch repair deficiency. Earlier this year, pembrolizumab became the first immune checkpoint inhibitor to be approved for colorectal cancer and was granted accelerated approval for MSI-high mismatch repair deficient colorectal cancers that had progressed following fluoropyrimidine, oxaliplatin, and irinotecan chemotherapy. Pembrolizumab was also granted tissue and site agnostic accelerated approval for the treatment of any adult or pediatric cancer that is MSI-high and mismatch repair deficient that has progressed on prior therapy. Since the approval for pembrolizumab was based on data from patients with a diverse array of cancer types, the degree of benefit seen specifically in colorectal cancers, the malignancy in which MSI-high and mismatch repair deficiency are likely most common, has remained imprecisely understood. On July 31st of 2017, Nivolumab was granted accelerated approval by the FDA for the treatment of patients 12 years and older with mismatch repair deficient and microsatellite instability high metastatic colorectal cancer that has progressed following treatment with a fluoropyrimidine, oxaliplatin, and irinotecan. The recommended dose of Nivolumab for this indication is 240 milligrams intravenously every 2 weeks. The approval for Nivolumab for metastatic colorectal cancers with high-level microsatellite instability and DNA mismatch repair deficiency in the refractory setting was based on the results of the CheckMate 142 trial, which was an open-label, multi-center, single-arm phase 2 study published in Lancet Oncology by Overman and colleagues. In the CheckMate 142 trial, 74 individuals from 8 countries with metastatic MSI-high mismatch repair deficient colorectal cancer who had progressed on or were intolerant of at least one line of cytotoxic chemotherapy with a fluoropyrimidine plus oxaliplatin and or irinotecan were treated with Nivolumab every 2 weeks at a dose of 3 milligrams per kilogram. Tumor mismatch repair and MSI status was assessed through local testing with immunohistochemistry for the DNA mismatch repair proteins and or PCR-based microsatellite instability analysis and was subsequently evaluated through centralized PCR-based MSI testing. The primary endpoint of CheckMate 142 was investigator-assessed objective response rate per RECIST criteria and was 31.1%, with 23 of 74 participants on this study experiencing a partial response and none having a complete response by investigator assessment. Among participants who experienced an objective response on CheckMate 142, duration of response was also assessed, and the median duration of response was not reached during the study period, which had a median follow-up time of 12.0 months. Overall, the median progression-free survival was 14.3 months, and 12-month progression-free survival was 50%. The 12-month overall survival was 73%, and median overall survival was not reached. All of the participants who experienced an objective response to therapy were alive at the time of analysis. There were no significant associations between somatic KRAS mutation status, BRAF mutation status, tumor PD-L1 expression status, or presence or absence of a known diagnosis of Lynch syndrome with likelihood of objective response to Nivolumab on CheckMate 142. 20% of study participants experienced treatment-related grade 3 or 4 toxicities, most commonly increases in serum amylase and or lipase levels. No deaths occurred on the study that were deemed to be due to treatment. Checkmate 142 helps clarify the magnitude and duration of benefits seen with immune checkpoint inhibitors in the palliative treatment of chemotherapy-refractory MSI-high mismatch repair-deficient colorectal cancer. The approval of Nivolumab as palliative treatment for this subset of chemotherapy-refractory colorectal cancer adds to the growing list of treatment options for patients with MSI-high mismatch repair-deficient cancers. Earlier this year, pembrolizumab, another anti-PD-1 antibody, was similarly granted accelerated approval for MSI-high mismatch repair-deficient colorectal cancers that had progressed following fluoropyrimidine, oxaliplatin, and irinotecan-based chemotherapy, and was also granted accelerated approval for the treatment of any adult or pediatric cancer that is MSI-high and mismatch repair-deficient that has progressed on prior therapy. Even though Checkmate 142 was a single-arm Phase 2 study with no control group, the significant response rates and durable benefits experienced by a sizable fraction of patients far exceeds the benefits typically observed with other drugs that are used for chemotherapy-refractory colorectal cancer, such as regorafenib or tipiracil with trifluridine. It is important to point out, however, that the benefits of immune checkpoint inhibitor therapy currently only apply to a small fraction of colorectal cancer patients. Even though roughly 15% of colorectal cancers are MSI-high and mismatch repair deficient, such tumors are disproportionately early-stage tumors. The exact proportion of metastatic colorectal cancers with MSI-high and mismatch repair deficiency is not precisely defined, but is likely no more than 5% of all such metastatic colorectal cancers. Nonetheless, due to the promising activity of immune checkpoint inhibition with pembrolizumab and nivolumab for this subset of patients, current guidelines from the NCCN and other bodies recommend testing all colorectal cancers for mismatch repair deficiency and/or microsatellite instability. Such testing is widely available and remains a critically important screen for underlying Lynch syndrome, which accounts for roughly 3% of all colorectal cancers, and now this testing also has significant treatment implications for individuals with metastatic disease that is refractory to cytotoxic chemotherapy. It is important to recognize that immune checkpoint inhibitors are not considered established therapies for colorectal cancers that are microsatellite stable and mismatch repair proficient. Furthermore, the efficacy of nivolumab and other immune checkpoint inhibitors in combination with cytotoxic chemotherapy and/or in the first-line metastatic setting remains unknown. Lastly, there are currently no data to support the use of nivolumab or other immune checkpoint inhibitors in the adjuvant or neoadjuvant treatment of colorectal cancer. It is also worth noting that, since this was an accelerated approval, further studies will be required to confirm the clinical benefit of nivolumab for this specific indication. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on immune checkpoint inhibitor therapy and the treatment of mismatch repair deficient colorectal cancer, please visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.